Good day. Today we are continuing basic life support. Defibrillation is the therapeutic use of electricity to depolarize the myocardium so coordinated contractions can occur. The term defibrillation is usually applied to an attempt to terminate a non-perfusing rhythm such as ventricular fibrillation or pulseless ventricular tachycardia. Cardioversion is the application of electricity to terminate a still perfusing rhythm such as ventricular tachycardia with a pulse, supraventricular tachycardias, including atrial arrhythmias, to allow a normal sinus rhythm to restart. By this definition, cardioversion is a less urgent procedure compared to defibrillation. Although the patient requiring cardioversion may be hypotensive or hemodynamically unstable rather than in cardiac arrest. Indications for defibrillation include ventricular fibrillation and pulseless ventricular tachycardia. Defibrillation is not indicated for asystole and pulseless electrical activity and is contraindicated for sinus rhythm, a conscious patient with a pulse, or when there is danger to the operator or others, such as from a wet patient or wet surroundings. Cardioversion is indicated for a hemodynamically unstable patient with ventricular tachycardia, supraventricular tachycardia, atrial flutter, or atrial fibrillation. It is also possibly indicated after failed pharmacologic therapy for the previously mentioned arrhythmias, especially if the patient becomes hemodynamically unstable. Cardioversion should be synchronized, which means the electric current will be timed with the patient's intrinsic QRS complexes to minimize the risk of inducing VF or ventricular fibrillation. Electrical energy can terminate an abnormal rhythm, but if inappropriately delivered, it could also induce ventricular fibrillation. This can happen if the electric shock is delivered during the relative refractory portion of the cardiac electrical activity. When preparing for defibrillation, check the patient and rhythm to ensure that a shock is truly indicated. Movement artifacts or loose leads may look like ventricular fibrillation. New defibrillator technology is available that can filter compression or movement artifacts to see through the underlying rhythm. However, when using AEDs, all manufacturers currently still recommend stopping all compressions and patient movement, such as during transport, before initiating analysis mode. Make sure that no rescuer is inadvertently in contact with the patient when the shock is delivered. Neither single nor double gloves provide the rescuer with complete safety from current, so we still recommend stand clear drills during defibrillator training, stand clear practice during actual defibrillation, and minimizing rather than eliminating the pause in compressions for defibrillation. If the patient is on a wet or conducting surface, we move the patient to a safe area and dry the body before delivering the shock. When using a manual defibrillation paddle, make sure that the paddles are either on the defibrillator cradle or on the patient's chest with minimal time in transit from one position to the other. To prevent inadvertent discharges, always point the paddles downward and never wave the paddles around or face them toward each other, especially when charged. This is to prevent inadvertent discharges or sparking. To avoid skin burns, remove all metallic objects and nitroglycerin patches from the patient. Ensure correct placement of defibrillation paddles or pads and remove all direct sources of oxygen to avoid fire. If paddles are used, do not allow the conducting gel to spread to within 5 centimeters of the other paddle. In patients with an internal pacemaker requiring defibrillation, ensure that the paddles or pads are placed well away at 12.5 centimeters from the pacemaker before discharging. Avoid prolonged pauses of more than 10 seconds to CPR when performing defibrillation. Thus, the emphasis is on minimal interruptions to CPR for analysis, a single shock instead of three stacked shocks, and immediate resumption of CPR without a pulse or rhythm check immediately after defibrillation. In addition, if a mechanical CPR device is being used, defibrillation can be safely performed without stopping ongoing mechanical compressions to reduce unnecessary pauses. Equipment used in this part of life support include the defibrillator, paddles or self-adhesive defibrillation pads, conductive gel or gel pads for defibrillation paddles, and related resuscitation equipment that includes bag valve mask devices, airway devices, suction, IV cannulation, and drugs. Defibrillators should be properly maintained and in a constant state of readiness. We recommend the use of checklists to identify defibrillator malfunction and ensure proper maintenance of batteries. Users should be trained in the proper use of checklists, and checks should be performed frequently, as often as every shift. Perform cardioversion in a resuscitation area with appropriate monitoring and standby resuscitation equipment in case the patient deteriorates or develops cardiac arrest. We place the patient in the supine position. We expose the chest and remove jewelry and medication patches. If the chest is very hairy in the areas where electrodes are to be placed, quickly shave the hair to ensure that the electrodes stick onto the chest. If the chest is wet because of sweat or because the patient has been in water, wipe dry immediately. Sweat or moisture on the chest will reduce adhesion of the electrodes. For a patient in cardiac arrest, defibrillation is part of the immediate resuscitation process. However, for an elective or semi-elective cardioversion, procedural sedation and monitoring before, during, and after the procedure are essential. We provide cardiac, blood pressure, and pulse oximetry monitoring, place an IV line, and make sure airway equipment, suction, and oxygen are immediately available. We obtain informed consent when possible. Sedation is typically provided with an IV agent such as etomidate, propofol, or midazolam. Regarding placement of defibrillation paddles or pads, there are several alternative positions. The first is the anteroapical position. We place one paddle to the right of the upper half of the sternum or the breastbone, just below the patient's right clavicle, and place the other pad just below and to the left of the left nipple in the axilla. With a female patient, place the paddle or pad just below and to the left side of the breast. Do not place it over the breast. This is the preferred position for a supine patient and when using defibrillation paddles. The idea is to maximize current flow through the cardiac chambers rather than along the chest wall. The second is the anteroposterior position. We place one pad at the left lower sternal border and the posterior pad below the left scapula. The third is the apex posterior position. We place one pad at the apex just below and to the left of the left nipple and the posterior pad below the left scapula. When using paddles, apply conducting gel or a gel pad and firmly place the paddles onto the chest wall with 2 centimeters squared of pressure. When using defibrillation pads, ensure that the electrodes are firmly attached and there's good contact by pressing gently with fingers over the center and around the edges to check for good adhesion. Good contact increases shock efficiency. In AED mode, check if contact is sufficient, and if it is insufficient for the defibrillator to operate, the check electrodes message will also be heard. Outcomes are better with larger electrodes of 12 centimeters than smaller electrodes or those less than or equal to 8 centimeters. For manual defibrillation, we prepare the patient and equipment as described earlier. CPR should be ongoing. We also check that the rhythm is VF or pulseless VT, and check that the defibrillator is in unsynchronized mode. Select the appropriate energy level. For biphasic machines, select according to the manufacturer's recommendation, which is 150 to 200 joules with biphasic truncated exponential waveforms and 120 joules for rectilinear biphasic waveforms. For monophasic defibrillators, it is reasonable to begin with an initial 360 joule shock. Apply the paddles or pads and charge. Check that no one is in contact with the patient or trolley and call out, "Stand clear." Discharge the shock. Continue CPR and manage according to the local resuscitation protocol. For automated external defibrillation or AED, prepare the patient and equipment as described earlier. CPR should be ongoing. Open the package containing the defibrillation pads with attached cable and connector. With the chest prepared, carefully pull off the protective backing from the pads and attach them. Turn on the device and follow the voice prompts according to your device. Initiate analysis of the rhythm and ensure that there is no movement during analysis. If a shock is indicated, the device will automatically charge up to a preset level. Check that no one is in contact with the patient or trolley and call out, "Stand clear." Discharge the shock and note that fully automated defibrillators do not require the operator's input to discharge a shock. Continue CPR and manage according to local resuscitation protocol. Cardioversion requires preparing the patient and equipment. You have to check the patient and the rhythm and check that the defibrillator is in synchronized mode. Select the appropriate energy level. For monophasic defibrillators, start at 50 joules for paroxysmal supraventricular tachycardia and atrial flutter and 100 joules for VT and atrial fibrillation. For biphasic defibrillators, follow the manufacturer's recommendations. Provide sedation with an appropriate agent when ready. Then apply the paddles or pads and charge. Check that no one is in contact with the patient or trolley and call out stand clear. Then discharge the shock and continue to monitor and manage according to local protocols. Internal defibrillation is indicated in a patient with VF or pulseless VT with an open thoracotomy. This could be in a patient with traumatic cardiac arrest, for example, or during open heart surgery. The procedure requires a special set of internal defibrillator paddles which should be connected to the defibrillator. Moisten the internal defibrillator paddles with saline and then place one paddle posteriorly over the left ventricle and the other anteriorly over the right ventricle. Hold the paddles firmly against the myocardium to ensure good contact. Begin with 10 joules for defibrillation and increase as needed. For pediatric patients, VF in children is relatively uncommon and the most frequent cause of cardiac arrest is usually respiratory. Thus, treatment should be directed toward preventing cardiac arrest by supporting ventilation and respiration. In the event of VF, use a weight-related dose of 4 joules per kilogram body weight for the first and any subsequent shocks. For VT with a pulse, cardiovert with 1 joule per kilogram synchronized. This can be increased to 4 joules per kilogram subsequently if needed. Special pediatric paddles or pads are available. Some AEDs also come with pediatric attenuator pads. In an infant, it is possible to defibrillate with the patient propped on the side using anteroposterior paddle placement. The aim of defibrillation or cardioversion is termination of the abnormal rhythm and restoration of a normal perfusing rhythm. Possible complications include skin burns, inadvertent electric shock to others, and defibrillation-induced myocardial damage. However, these complications are minimal compared to the ultimate complication of patient death if defibrillation is unsuccessful or not attempted. Our source is Tintinalli's Emergency Medicine. The next video will cover advanced cardiac life support. Thank you.